So going to go on to limb neurological examination now. So this is what you don't want to get the two muddled up, which probably isn't very helpful me doing a presentation on one after the other. But just look at what it says in the station information and what examination will be better for that. So for limb neurological examination, so very similar. So have an overall base structure that you can fall back onto, that if ever you get stuck, you can take a moment, take a deep breath and think back to this structure and get yourself going again. To have a knowledge about each of the components of each section and then how to apply this in an auscultation. And again, practice in your own time. And I think for neuro examinations in particular, it's important to, if you can, practice on non-medical friends and family, because there's some of the movements and things that you're going to want people to do, which might be quite tricky to explain. So for a station for neurological examination, it might be that you are the F1 doctor on a GP rotation. You've now got Mr. B with weakness or numbness perhaps in, say, arm or leg, and then you're going to be performing the relevant examination again. So if it says weakness and numbness, you're thinking neuro. If it says pain, swelling, then you're going to be thinking a joint. So what are your components for a limb neurological examination? How are you going to structure? Can you think of any particular components for it? Yeah, good start. Let's see if we've got a few more coming through. Yep. Yep. Think about, yes, so you will be thinking about upper motor neuron, lower motor neuron. Yep. There's one thing I haven't seen yet. I don't know if anyone can. There you go. Yeah, I've just spotted it. Inspection. So yeah, so that's your first step of any clinical examination, regardless of what it is inspecting. So take a deep breath and step back. Well done. So there's a good selection of things there, and there's various other things that you can be doing as you go through. So this is how I remember it. I remember ITP, RCS. Sometimes things are done in a slightly different order. So don't worry if you do ITP, CRS, or whatever else it might be, if you count proprioception as separate or whether you put it in sensation, it's all fine. Just as long as you remember to do a bit of all of them and you've got a way that you remember, that's the main thing. And then these are the things you're going to need for your examination. So you're going to need a tendon hammer for your reflexes, and for your sensation, you're going to need, this is called a neurotip. So it's got the sharp end and it's got the blunt end for your sensation. You'll need cotton wool as well, which you will sort of pull out a little thread of it to make for your light touch. And then a tuning fork as well for your vibration sense. And also it can work for your temperature sensation as well, because it's a cold metal thing. So again, prepare yourself, prepare your patient, take that deep breath, take a step back, have a think of your structure and start your inspection. And do the same things for the patient. Depending on which limb you examine, if it's the upper limb, you're going to want sort of from the shoulder and all the way down the arm exposed, so the patient in at least a vest. And the legs, again, you're going to want the entire legs exposed, so underwear for the lower limb neurology. On your inspection, so for your lower limb, you're going to want the patient standing up first of all, if they're able to. So again, checking in on your patient, are they able to stand? Do they need any mobility aids or orthoses? And that will be part of your inspection. Look at how they hold the position. Is there a particular position their upper limb is held in? And that might give you some keys. Any deformity to the limb that you can notice. Symmetry, again, you've got 2 arms, you've got 2 legs, really nice little guide onto what might be going on. And then gait as well, again, for lower limbs and spinal examinations, you're going to want to see their gait. And these are the things, this SWIFT, so I saw someone put it in the Q&A, SWIFT is the way that you can think of some key findings that you might want to look out for. So have they got any scars? Have they got any wasting? And this will be a lower motor neuron sign. Have they got any involuntary movements or fasciculations? Fasciculations are little ripples that you might see in the muscles, whereas involuntary movements are the whole sort of limb is moving or part of the limb. Or any tremors, and these might be a resting tremor, they might be when they go to move, sort of an intention tremor, and there might be particular characteristics, so perhaps a pill rolling tremor, which is the classical tremor seen in Parkinson's disease. Tone. So I've put this picture here of a handshake. So this is how I find is the best way to approach tone in the upper limb. So you ask the patient to, can you take my hands? And you offer them your hand as if shaking a hand. And then you want the patient to be as floppy as possible. So I normally talk to the patient whilst I'm doing this. So it doesn't really matter what you say, find something or anything to talk to. And that's sort of a method of distraction. So just say, oh, just let your arm go really floppy and then chat about whatever you want to chat about. And you're going to be examining each joint and hand. So whilst you're holding the patient's hand, you're using the other hand to isolate the joint. So first of all, you start by rolling the wrist. You'll then move your hand up. And so you can move the elbow and then you'll do their shoulder. Whilst you're testing their tone, increased tone will suggest upper motor neuron lesion. Reduced tone will sort of suggest lower motor neuron lesion. And cogwheeling. So this is as you're moving the wrist, moving the joints, the sort of on and off. That's a key sign in Parkinson's. Whereas you might have heard of things like clasp knife or lead pipe rigidity. These are more in upper motor neuron lesions. In the lower limb, so you're going to have the patient sitting on the bed with their legs up, so 45, sitting in the bed at 45 degrees, and roll their legs. So you put your hands just above and below the knee and roll their leg. You should see the foot sort of flopping independently. When you roll the leg left, the foot shouldn't be moving in time with it. It should be sort of flopping slightly independently. So look out for that. And then you might want to test for clonus as well. So you've got the diagram here, and this is an upper motor neuron finding. So what you do is you hold the foot and you roll the ankle, make sure they're nice and floppy, and then you bend the foot backwards quite sharply. So dorsiflex the ankle and hold it there. If the patient has clonus, you will see the foot tapping like this, or you'll feel it in your hand. And sources differ, but certainly if you see quite a few beats of clonus, that's abnormal. 1 or 2 is normal, but above 5 is definitely abnormal. Again, find some YouTube videos and see what they show. There's some quite good ones for clonus, and it can go on and on and on. So power. So you're going to assess each muscle group in turn. And again, with, as I said in the previous slideshow, act with purpose. So if you're assessing their shoulder abduction, these are quite strong muscles, so you're going to want to put quite a lot of force. For some of the lower limb power, your arms probably aren't going to be as strong as their legs. So if you are able to resist them extending their knee, then there may well be a degree of weakness there. So do think about what is expected. So obviously legs are very strong muscles. Whereas if you've got an elderly patient, you might not expect that from them. So just be aware of what is expected from those muscles. But you're going to assess one group at a time. You're going to want to isolate that joint. So if you're examining elbow flexion, you're going to want to hold sort of the upper arm to make sure that they're not actually pulling with their shoulder. And compare left to right. So once you've assessed right shoulder abduction, you then assess left, and so on and so forth. Don't do the entire limb and then move on to the other one. Unless, of course, in Neurology, you're instructed just to do the certain limb that's in question. The way you will measure their power is with the MRC power scale, which you can see here, and just have a read through it or have a look at one, write it out, copy it up, whatever you like. I think the one that is the most confusing is level 2 here. So active movement when gravity eliminated. So the other 3 are quite straightforward. So 5, full power as you'd expected. 4, you're doing your movements, but they're a little bit weaker than you would expect. 3, they can move their arms up, or whatever it might be, but as soon as you resist them, they can't manage it. Active movement when gravity is eliminated is if they can, perhaps if their arm is lying on the bed, they can move it, but they can't actually lift it in the air. So that's when gravity is eliminated. When that limb or the joint is fully supported, then they can move it. And then 1 and 0 are as you'd expect. I'll just put this slide here for a couple of minutes, or just a little while. I won't go through all of these, but just be aware of your myotomes. Again, you might find things, different sources, so show things are slightly different. But generally they're fairly similar. If it says, for example, for elbow flexion C5 to 6, some places might say C5 alone, some places might say C6 as the primary one. But we've just got those there. If you can find a way of remembering them, do some fantastic little dances with your legs as you're revising, whatever it might be. If you can remember a way, then that's whatever works for you. Okay. So your reflexes, again, you're going to compare your left to your right. You want to relax the limb as much as possible before doing your reflex tests. You might need to distract the patient. By distracting, so what's commonly quoted is if you're testing upper limb reflexes, get the patient to grit their teeth, so 1, 2, 3, and the patient's concentrating on gritting their teeth whilst their limb goes nice and relaxed, and then you can elicit the reflexes. For the lower limbs, you might get them to grasp their hands like this, and you say 1, 2, 3, and they will pull against themselves like this, and that will distract their upper limbs whilst leaving their lower limbs to go nice and floppy, so you can elicit their reflexes. An increased reflex, so brisk reflex might suggest an upper motor neuron. Decreased reflexes might suggest a lower motor neuron lesion. And then in the lower limbs, you've also got the plantar reflexes or the Babinski reflexes. And this is where you use something fairly sharp to scratch along the sole of the foot. You should expect toes to curl. If their toes extend and splay apart, that is a positive finding, and it's a suggestion of an upper motor neuron lesion. And these are the nerve roots that they're assessing. So a nice way to remember it, for the lower limbs, perhaps you might have come across. So the knee jerk, L3, L4, kick the door. So as your knee extends, S1, S2, foot in shoe. So you're pointing your toe down to put it in your shoe. But again, everyone's got a slightly different way that helps them. So coordination next, and this is one where the instructions are quite important. So having a go at getting your wording right can be useful. So again, comparing left to right. For your upper limbs, you're going to do the finger to nose test. So get the patient to put the finger on their nose and then reach and touch your finger. And it needs to be at their full arm length away. You don't want them to be going like this. You want them to be reaching for the full length. You'll be looking for things like intention tremor. So that's when they get close to their final, then they'll start to shake, or past pointing and they miss this. And then distidocokinesia, this is this movement. Hopefully you've all seen it. And whichever way works best to instruct patients to do this, because it can commonly be a really confusing thing to suggest. And then your lower limbs, so similar things. Your heel, put your heel on the patient's heel, or put the patient's heel on their ankle or the heel. Draw it up to their knee, and then to your finger, which should be a full sort of leg length away, and then go round in that circle. Any incoordination can suggest a cerebellar lesion, or it can suggest muscle weakness. If someone's got sort of some significant muscle weakness, then there might be some tremor just purely from the weakness. And then bradykinesia, if they're doing things very slowly, then again, that's a suggestion of Parkinson's disease. And then finally, sensation. So you've got different methods of sensation. I think by the time you get to this in your neurological assessment, you might sort of be running out of time. There's quite a lot to cover, so you may not have to do all of them, although this might be the key point of the assessment. So you might be moved along. Your assessor might say, yeah, assume you've done reflexes. Yeah, assume you've done power. And that might suggest to you actually that there's something to find in the sensation setting. If you're being moved on quickly through the power and the reflexes, you might think, well, there's nothing to find here. There's nothing with the motor system. So then when you get to sensation, maybe bear in mind that you might be expecting to find something there. So first of all, you're going to demonstrate on the sternum. So assuming that there is normal sensation in the sternum, you will demonstrate it to them then and say, can you feel that as sharp? And they will say yes, hopefully. And then proceed to examine on the limbs, or can you feel that as blunt, or can you feel that as a light touch? Same thing with the temperature, so using your tuning fork because it's a cold metal item on the sternum first, and then assessing the temperature. And you'll be moving along in the dermatomes. So I've got a picture of the dermatome map, but again, just have an awareness of where you're going to be assessing the sensation in each of these places. And your pinprick or your crude touch sensation and your temperature sensation are your spinothalamic tracts. And then the fine touch and vibration and proprioception will be your dorsal columns. Okay, so that's linking it, your sort of clinical findings to your anatomy and physiology. Vibration, you'll be starting off with the interphalangeal joint of the thumb. If they can't feel the vibration sense there, you'll be moving more proximally along the bony prominences of the upper limb. So your IPJ, and then you'll be moving on to your MTPJ to one of the bones in the wrist, and then up to the elbow, and similar things in the lower limbs. And proprioception, so it's important that you hold either side of the joint, and that is so that the patient can't sort of use the sensation of how you're squeezing the finger to identify where the finger is going. And you'll demonstrate this first of all with the patient's eyes open, so you'll sort of move the finger down and say, this is down, this is up. You'll get them to close your eyes, and then you'll give a bit of a wiggle, and then you say, what is this, and what is this, to assess their proprioception. So that you'll be doing all of these things, so pinprick, temperature, cotton wool in the dermatomes, and then vibration and proprioception you'll be doing sort of distally initially, and if that's fine, then you can be reassured by that. Also bear in mind if there is any reduction in sensation, particularly distally, you might want to start thinking about a glove or stocking distribution of paresthesia. And this is particularly in a peripheral neuropathy, such as diabetes. And so if you start to notice that actually maybe there's some lack of sensation distally, then you will repeat your pinprick or cotton wool sensation, sort of moving up the limb. And you might notice there is a cutoff position, and then that can suggest that's a peripheral neuropathy rather than something that's sort of dermatomal. So here is our dermatome man, and these dots on the dermatome person is where you will assess for these points of sensation. So your C5 is just on the outer portion of the sort of upper arm by the elbow. C6, 7, and 8 are on the fingers. But bear in mind, these are different to the locations that you will feel for your median, ulnar, and radial nerves. So try not to get those confused. And then T1 is just on the inner portion of the elbow. And then on the legs, most important one, I think, or the easiest one to remember is L3 is on the knee. And then I remember L4 and L5, L4 indoors, L5 outside. If that helps anyone, then feel free to use it. But again, whatever works for you. So L3 knee, L4 indoors, L5 outside. But you will be testing L5 on sort of the first web space of the toes. It's because it goes from sort of the outside of the lower leg across the dorsum of the foot towards the big toe. So just have a note of where those dermatomes are on the legs. So I've got a bit of a quiz. So if you want to open up on Menti, and we can go through this. So I think there's 4 or 5 questions. So I'll give you a bit of a moment to open up Menti. And this is sort of linking it a bit more to some clinical findings. Yeah, hopefully a fairly straightforward one to start with. So you may well notice some forms of tremor with cerebellar disease as well. Motor neuron disease, if they've got some muscle weakness, you might notice some tremoring, or obviously some weakness with a CVR stroke. But the classical pill rolling tremor and cogwheeling, increase in tone, will suggest that it could be Parkinson's disease. On their gait, you might also notice a shuffling or fenestrating gait with sort of bradykinesia on some of the sort of foot tap tests and things. There we go. So, yeah. So the patient is able to lift their arm, but they can't resist you. What is their MRC power score? So they can lift it up. You ask them to resist. They can't do that. So yeah, so most of you are answering 3, which is correct. So remember, 5 is full power, so they've got full strength in that arm. 4 is slightly reduced power, so they're able to lift and they're able to resist you, but not as much as you would hope. 3 is when they're able to lift it against gravity, but they can't form any sort of resistance. So that's why this person is 3. If it was 2, then they would be able to move it when gravity is eliminated. So they wouldn't be able to lift their arm off the couch, but they would be able to move their arm on the couch. And then 1 is just a flicker of movement, and 0 being nothing. So well done for most of you there. So the answer is 3. So we've got a patient presents with foot drops. This is a test of your dermatomes here. So, and they cannot dorsiflex their ankle. So they can't, so imagine this is my foot, they can't lift it up. Which nerve root might be responsible? I've got some conflict of interest with this one. So if you remember some of the ways of remembering them, so L3, L4, kick the door, so that's your knee extension. S1, S2 is in the shoe, which is plantar flexion, so pointing the toe. So it's L4, L5, which is dorsiflexion. So the correct answer is L4, L5. So that's where having a couple of key points that you can remember might come in helpful. So L3, L4, kick the door. It's not that one. S1, S2 in the shoe, so that's plantar flexion, so pointing the toe. Whereas L4, L5, the handy one to remember L5 is it's also sort of extending the big toe, and this is quite a sort of key point that that you can use to assess. And so that's sort of a similar movement to dorsiflexing the ankle. So which nerve is responsible for the triceps reflex? Does anyone remember this one? Oh. So the supinator reflex is C6, biceps is C5, C6, triceps is C7. Your T1 is your abduction of your fingers, C8 is flexion of the fingers, and then C7 is your triceps. Okay. So the correct answer to that, well done most of you, that is C7. And then last question, so where would you test the S1 dermatome? So this is specifically where would you test it, not necessarily where S1 dermatome reflects. So I think I'm running out of time a bit, so I'll give the correct answer is the lateral side of the foot. So yes, the S1 dermatome does extend, so it's a bit of a tricky question there. So from the lateral side of the foot and some of the sole of the foot and up the back of the calf, but you test it as the most reliable area that it innervates is the lateral side of the foot. So that's where you would test it. So there we go. So a quick summary. So as always, prepare yourself and the patient and then move through your structure, whatever order that might be in, but make sure it's organized. You'll always then thank your patient and get them to redress and summarize your findings with the relevant positives and important negatives. And you're completing the assessment would be, you would want to do a neurological examination of the remaining limbs, so upper limb if you've done lower and lower if you've done upper. You may also want to do cranial nerves and cerebellar examination. Consider a diabetic foot, and I've put neurovascular there, but that should say vascular examination. Okay, so I think that is everything there. I think I've gone a bit over on time on that one, but if there's any quick questions, I can answer them.
No worries. We'll go through a few quick questions, and after this will be the break anyway, so we're not going into anyone else's time.
Okay.
So we'll see if any. I think one's come through from the previous session. I think this came through before. And it just says, in clinical practice, how are suspected dislocations and fractures assessed in terms of trauma? Is there ever a need to cut off clothes instead of removing them normally?
So yes, in a trauma situation, when you don't want to be moving that limb, especially with major trauma, you'll be doing C-spine control. You may well need to cut off that item of clothing. In trauma, so if it's top, you don't want to be moving their neck to get it over their top, so it may need to be cut off. If they've got a significant deformity suggesting that they've got a major fracture, perhaps an open fracture, if they've got particularly nasty dislocation, they're not going to be able to move that arm or that leg to navigate their way out of their clothes. Or if they've got any penetrating wounds as well, so if they've got something going through the item of clothing into wherever it might be, you're going to have to cut off the clothes around that item. And in terms of assessing sort of fractures and dislocations in terms of sort of trauma situations, then that will be a sort of a whole different situation. You might have come across sort of advanced trauma life support or trauma life support guidelines. So they will be, you will need to go through a full sort of A to E assessment, sort of with your mind on trauma for those sorts of things, rather than the standard looking at that injury in isolation, because you don't know what other injuries there might be for that patient in that situation.